Hello and welcome to the Answers for Cancers podcast. I am your host, Anne-Marie Fay.
And I'm Michelle Matthews.
Together with some of Ireland's leading experts, we want to unravel what it truly means to have cancer.
From consultant diagnosis to treatment plans, from managing your symptoms to supports available, we have it covered. So whether you're a nurse working in oncology or have been personally affected by cancer, this podcast is for you.
Today on the podcast, we are joined by Kate Police, also known as Fertility Menopause Support by her Instagram followers. Kate has kindly joined us today to cover a much requested topic of cancer and menopause. We know that cancer treatment can cause early menopause, and often this can be an extremely challenging thing to manage on top of being hit with a cancer diagnosis and all the treatments that can be involved with this. Kate helps us understand the difference between perimenopause and menopause, some of the more common and least common side effects associated with the menopause, and medications and strategies for managing these. Kate has helped us to demystify HRT and also explains the importance of preparation and conversations with your treatment team when you know a cancer treatment has the possibility of putting you into early menopause. Thanks, Kate, for all your work you do in this area and giving people a voice on this topic. We hope you enjoy this episode. Hi Kate, welcome to the Answers for Cancers podcast. Thanks for coming to see us today. So I just wondered if we could start with maybe just telling us a little bit about yourself and what you do.
Thank you very much both for having me. So my background is I'm a specialist women's health nurse. My areas of specialism are fertility and the menopause. I used to work in clinic, but I now work a combination of lecturing at Dublin City University on their nurses ambulatory gynecology pathway. It's a lot of words, I know. And I also work independently, providing menopause and fertility support, advice and work-based training. And I'm also currently studying for my part-time PhD, which is looking at women's lived experiences of a premature menopause.
Oh, amazing.
Wow, not easy on yourself.
Absolutely. And we actually found you do great work, and your Instagram page is amazing as well. And that's actually how we initially connected with you. But we might start with maybe just breaking it down to the most simplest kind of forms, and we're going to talk about menopause today. But can you just tell us what the menopause actually is?
So if we talk about the medical term menopause, what we're referring to is that a woman goes 12 months and 1 day without any periods. So it sounds really simple, doesn't it? So 12 months, 1 day, tick the box, that's it, menopause. So the term menopause, we're just referring to that 1 day after you've had 12 months without any periods. But then let's break it down a little bit. We have a period of time, pardon the pun, before 12 months and 1 day, which we refer to as the perimenopause or the menopause transition. And this is the period of time when hormones start to begin to fluctuate and change. So our ovaries produce estrogen, progesterone, testosterone, and all of these hormones start to fluctuate and change for the majority of women once we enter our early to mid 40s. So the average expected age of women going through the menopause in Europe is about 50 to 52. So if we backtrack and say, well, the perimenopause or the menopause transition can start anything from a few months to a few years before that, anything up to about 7 years, then potentially it is quite common that women might start to see symptoms in their early to mid 40s.
Okay. Well, my next question was going to be, what's the difference between perimenopause and menopause? But I'm right, have I taken that? So if you're 12 months and a day, you're in the menopause, and prior to that, you're perimenopause. Is that fair?
That's absolutely fair.
Perfect.
Yeah.
God, I've never understood those terms before, because when people have said, like, I'm in perimenopause, I just never really understood what it meant. I thought maybe it's because you're not 50 yet. You know, I just didn't really understand the terminology. So that's very good. Thank you for explaining that. And then you mentioned some different types of hormones there. Are there specific blood tests that can be done to check if someone is going through the menopause? And what are these tests?
So the guidelines is that we don't need to do any blood tests, particularly if a woman is over the age of 45, because what we know is that those particular hormones that I've mentioned, the estrogen, progesterone, testosterone, they start to fluctuate quite a lot. So let's say we checked your bloods, Anne-Marie, on the Monday and we said, oh no, they're a little bit abnormal. And then we checked them again on the Wednesday and we said, oh no, they're all fine. So actually it's really important to look at the bigger picture and look at that patient, holistically as with everything included in the puzzle, because we know that blood tests can be quite unreliable because of the fluctuations that happen. We can do blood tests to check some hormones, so particularly in younger women, if we because we know that menopause doesn't always happen at the age of 50 to 52. We know that younger women, unfortunately, can also experience an earlier or a premature menopause. So if you are younger, we would probably want to do some blood tests because we wouldn't be expecting those hormonal changes. So we would first of all look at testing follicle stimulation hormone, luteinizing hormone, which is what your pituitary gland, your brain produces. And then we would also look at checking the estrogen, progesterone and testosterone, and obviously amongst other tests as well. Because obviously what we're looking to do is see if there's any abnormalities.
Okay.
And would you, when you say that you don't necessarily have to do blood tests on everybody, and you say you have to look at the patient holistically, would, if somebody was presenting with maybe really symptomatic, would that prompt you to then maybe do some blood tests at that stage?
Yeah, absolutely. It's obviously looking at the patient in front of you, speaking to them, understanding their symptoms, what's their journey like, because as we can appreciate, getting information out there now is so much more easier than it used to be, but obviously a lot of patients are not sure which information to trust, where to go, where to start. So actually it's looking at that bigger picture and sort of saying, what symptoms have you got at the moment? What are you finding, that you're struggling with? How are you feeling in yourself? And then looking and discussing, treatment plans that help with that. But also if we're just talking about, general menopause, and we have a patient and we're thinking, is it menopause? They're in their late 40s, they've got these classic symptoms. But also we want to rule out anything else, because as we know in medicine, some symptoms can cross the borders and sometimes can present in one condition and actually might be another. So there's nothing wrong with also looking at underlying causes and checking that there's nothing else, because that can also be reassuring when you're kind of doing your detective work. Oh, the thyroid blood tests are normal. There's no vitamin deficiency. There's no infections, things like that, because that helps us put the puzzle together.
Mm-hmm. For a while, HRT had a really bad rep and people associated it with developing breast cancer. Can you help us demystify this? Because I feel like in the last couple of years, again, people are talking about HRT and there's been a lot of studies done, and maybe you could tell us a little bit more about it.
You're absolutely right. So it was a little while ago now. That shows you how time is flying. But the Women's Health Initiative study in the early noughties actually suggested that potentially there was a risk with HRT and breast cancer. This obviously portrayed in our wonderful media, and things did get a little bit out of control. There were lots of media articles, there were lots of things in the media. So obviously a lot of women saw this and stopped their HRT, and as you say, HRT got a bit of a bad rap. But actually when we closer looked at the studies, we actually know that these studies have been kind of defunct now. And the key thing is, because these studies, first of all, they followed older women, postmenopausal women, so no problem with that. But we know as we age, more women are likely to get cancer because the risk goes up for all of us as we age. They followed postmenopausal women, and they also followed women who were using what I tend to refer to as the older forms of HRT. HRT and the way that the drug is synthesized and made has made some radical changes over recent years. But this particular study followed traditionally the older methods, so the older tablet HRT. So it didn't give us that fair and accurate result. But what it did do was understandably scare a lot of women, a lot of misinformation, and women weren't sure whether or not they could trust to take it and whether or not they wanted to take it. I think the key thing is, I always say to any ladies that I see, there's no magic bullet with menopause. I'd love to say that, I've got this one pill and it solves everything, but actually that's not the case. It's very much a toolkit, and HRT can be an essential part of that toolkit. First of all, if you want to take it. Second of all, if you're able to take it, so there's no contraindications. And thirdly, sometimes you have to think about it that I'm taking HRT, but also I need to think about other things such as lifestyle factors, because as we say, it's not just one thing, it's all of those things that come together and make a big difference. And there's a really good poster from the British Menopause Society. I'll share it with you when I get home, because a picture can speak 1,000 words, and I use this all the time with my ladies. And it's basically got a line of people, and it will say, well, this is the risk if you do nothing in the population, there is a risk. And then it says, this is the risk if you take HRT, and there's 2 or 3 extra people on the list. But that's the same as if you take the pill. And if you asked how many women they took the pill, hands would be literally rising up. There's also a similar risk if you smoke. There's a similar risk if you drink alcohol. The risk doubles. There's more and more people in the line if you're, for example, have a BMI over 30. So it actually helps women to understand that there's a risk in every drug we take, and also in everything that we do, but it's understanding what that risk is for them. And also it helps to educate that actually diet and lifestyle are just as important when we're looking at this and we're looking at risks and understanding. and that actually there can be less risks, for example, if you've had a hysterectomy, because you're not using progesterone, so you're just using the estrogen. So it's understanding where that might fit for that particular patient when they can help with decision making.
So there is one cohort of people that HRT is not recommended for, and that's people that have hormone positive breast cancer or a history of hormone positive breast cancer. But we know that obviously these people still get the menopause and can have really severe symptoms. So can you suggest any other strategies that are safe for these people to help with the symptoms that they may be experiencing?
I think it's important. The first thing I always say to this particular group of patients is, because we know that that's one of the most effective treatments for menopause symptoms, HRT may be off the table for this group of patients. It's actually having that initial and open discussion to understand what symptoms are affecting you, what symptoms are impacting your quality of life. Because what we do know is, obviously, as we've talked about, when we think about menopause as that at the expected age of that kind of gradual, slowly tap that stops dripping, with surgical or medical menopause, we've stopped that tap full flow. So these ladies are potentially likely to going to get some symptoms that may have a big impact on how they're feeling. So I think the first thing I would say is to have a discussion as to what are the symptoms, because when we think traditionally about hormone replacement therapy, it's kind of like that umbrella that we can treat a variety of symptoms with the HRT, because we're topping up or we're replacing the hormones that the ovaries are no longer producing. But this may not be possible for this group of patients. So it would be then saying, well, which symptoms are you really struggling with? What are you finding difficult? So some ladies might say to me, it's the vasomotor symptoms. So not everyone gets vasomotor symptoms, that, oh, I'm feeling really hot. Oh, no, I'm feeling really cold. So is it vasomotor symptoms? Then we could look at medical options such as a drug called clonidine, an old blood pressure drug, antidepressants. And, just to give you hope for new research, I mentioned that there is potentially a new drug coming. The FDA in America have approved a new drug with a very unusual name. I think I've said this right, Veoza. Sounds a little bit exciting. And this is going to be working, rather than working on hormonal changes to stop flushes and sweats, it will be working on a chemical in the brain called neurokinin B, which helps to regulate body temperature. Okay. So for women who can't take hormones or don't feel that that's right for them, this gives them another option coming on the table, and it gives us some positivity and hope to know that studies and things are coming, because obviously a few years back there wasn't a lot that we could offer.
Yeah.
Also, as we've said, is there any other medication traditionally that we might be able to use for other things? So, even if we're talking about something like cognitive behaviour therapy, which is just as effective in the first few months as taking medication for sleep, is that an option? And I have a colleague and friend who has just done the course that the British Menopause Society run, to actually train to do CBT therapy for patients. Is it going to be things such as mindfulness, meditation, other alternative therapies that could be an option to help manage symptoms? But traditionally, as you say, focusing on particular symptoms rather than the kind of umbrella approach. And what we were saying in conversation, not being afraid to say to your doctor or whoever you're seeing for medical advice, I need some more support in this. What would you recommend? Where can we go from here? Because our job as healthcare professionals is to obviously listen to you as a patient. You're the most important part of the team here. And then think, where do we go next with this? Do we need to refer you to a specialist? Do we need some more support? Can we look at medication options? Can we look at different therapies?
Yeah, it's brilliant to see what people are doing to, better themselves, better educate themselves and support women in the area of menopause. Like you said, one of your colleagues going and doing the CBT course, it's great what people are doing. I suppose myself and Anne-Marie are acutely aware of the psychological distress that a cancer can cause people, and we're acutely aware of the people who go through a kind of all of a sudden immediate surgical or medical menopause because of their cancer. I wonder, can we just talk about the psychological distress that can cause, and just if you had any strategies that you could recommend for coping with this?
I think it's really important to think about the cognitive symptoms following a surgical, medical or premature menopause, because I think that's one of the most important. If I were to think of younger patients that I've spoke to, or patients that are, as you've said, surgical menopause or medical menopause patients, it's often those particular cognitive symptoms that they find difficult. So that can often be changes in mood, that can often be feeling very anxious, it could be a loss of confidence, it could be feeling depressed, it could be enraged at your husband, for example, or your partner. And often it's very easy, isn't it, to think about physical symptoms. You've had surgery, it's, I've got a physical symptom, my wound's healing, or this is happening. Yeah. But actually, when we're talking about psychological or cognitive symptoms, we always talk about this. So I think the first thing I would always say is, first of all, don't be afraid to talk about it, because that can take quite a lot of courage, can't it? To actually say, I'm having a really bad day, or I'm really sorry, I'm really forgetful. Nobody wants to admit that. Nobody wants to, we'll all laugh and say, why are you in the room? What happened? Did you forget why you were there? But actually to be able to say, I'm actually feeling a little bit low today, or I'm feeling really forgetful or really anxious. Sometimes just saying the words can be really, really helpful to you and whoever your significant others that you're with. I think as practitioners, we have to take the time to, I know time is our greatest asset, that we're constantly thinking we need more time with patients, we need more time. But actually to say, how are you feeling today? And most patients say, oh yes, I'm feeling fine, but that's not really what we're asking. How are you feeling? How's your mood? So when I see patients, I think that's probably the thing that I'm able to give them. I'm able to give them time. So I'll say, how are you feeling? Instead I'll start to ask open questions. How's your mood? Do you feel anxious? Do you feel, under the weather? Do you feel low? How do you feel? Because actually it's kind of digging a little bit deeper. And it may be that there's a variety of different strategies that can help, whether or not that's having a conversation with your loved ones and partners, medical options, as we've talked about, talking therapy, meditation, yoga, even down to simple things as, right, okay, I need to introduce a few coping strategies. I'm going to have a notebook, or I'm going to have a note on my phone where I can record things so I don't forget. Or I'm going to just say, can you send that to me in an email so that I've got that? But that means actually reworking how you'd normally cope with things, how you'd normally function. And that takes a little bit of time, and it takes a little bit of a while to get your head around it. So actually it's a change in behaviour and support.
Yeah, and you mentioned something earlier about being able to plan a little bit for the menopause as well. And sometimes, when you're with the cancer diagnosis, like you said, Michelle, and when you're having surgery and chemotherapy, radiotherapy, you don't sometimes have that time. But actually, you were saying it can be really beneficial just to even have one or two conversations before the treatment kind of goes in full swing, which can really help psychologically.
100%. You have that ability to, not necessarily have a foolproof plan in place, because I don't think one of those exists for any patient's journey. But actually, you have that ability to say, it's very likely that after this particular surgery or medical intervention that this is going to happen. So could that be a surgical or a medical menopause? These might be some of the symptoms that you might get. These might be the most common symptoms. They could happen straight away, or they might happen a few days or a few weeks later. Because I think sometimes even just having that awareness and having that education, you don't feel as panicked, and versus that kind of train on the speeding tracks, and then 3 weeks later you're sat in your bedroom recovering, thinking, well, I'm all hit, my wound's healing really well, but why am I feeling really unwell? Absolutely. Why have I got these cognitive symptoms? What's happening? And as we've said before, we're kind of steering these patients through a high-speed train, because we've got to get them through, we've got to get their surgery, we've got to get all of these things done, which is fantastic. And what we actually have now is we have more women surviving after breast cancer. Again, how that is amazing. But now we need to flip the switch a little bit and say, more women are living longer, great, but how can we support them post-surgery, and not just immediately, but actually afterwards? What support do they need in their recovery as a patient, and potentially if they've been affected by surgical or medical menopause?
Yeah, absolutely. Yeah, because I think it can be so difficult for people, like they're just, as you said, put on this fast track, and they have so many things happening one after another, and you're really task focused on getting these things done, and then it's only afterwards all of these side effects can hit, and a lot of them can be associated with menopause. But I also imagine it's kind of difficult to decipher, well, what's from the menopause and what's from just everything that I've just gone through. But as you said, at least if people can plan and be a little bit more prepared, maybe when this happens, at least they've got a plan in place for themselves then. I suppose we might talk about some of the most common side effects and some of the kind of not so common side effects, if that's okay, and some of the tips and tricks for managing them.
So potentially when we look at menopause, as we've said before, there's actually over 36 symptoms. And I'm a great believer that maybe they'll find more and more as we go on, because actually, as we've said, hormone receptors all over the body. So we do need to think very holistically. So as we've said, some of the most common symptoms, I'm basing this on the patients that I see when I'm asking them, well, which menopause symptoms are you finding, most difficult? We've talked about vasomotor symptoms because that's the one everybody always associates, hot flushes, sweats. So that is potentially about 40 to 60% of patients. And sometimes that can be cold flushes, hot flushes. Yeah. There's no specific blueprint. You know, some ladies will say it feels like there's a fire burning up from my feet. Some ladies will say if my head gets any redder, it will implode. So there's variations with how that is. Then if we're kind of looking down the line, some of those cognitive symptoms that we've mentioned, they're more likely to be symptoms that present. So that low mood, feeling very low, feeling very flat. A really good way to picture that is a lady said to me, I said, how is your mood? She said, I feel grey. The whole world just seems grey. Wow. And these may be women who've never had depression in the past or any other issues. So it might be a bit of a shock for them, because they might think, well, I should be feeling great. You know, I've had my diagnosis, I've had the surgery, things have gone well. Yeah, I'm feeling really low, I'm feeling really flat. We've talked about feeling really anxious, so never suffering from anxiety, but having palpitations, anxiety feeling. We've talked about potentially a loss of confidence, so things that you always did just all of a sudden seem a little bit scary. And as we've said, we've talked about that really low mood, so you weren't depressed before, but now all of a sudden you think, well, what's the point? I'm feeling really low. Because the most effective area for the hormonal changes is your brain. Your brain's had all these hormones through your reproductive life from when you were a young girl and started your periods, and they eventually settled down if they did for you. And then all of a sudden we've taken them away. And you know they're not there, but your brain doesn't. So your brain's saying, hang on, can I have the hormones back, please? So your brain's having to adjust to this really, really big shift. And they've scanned women's brains going through their menopause journey. So we know it's true. Yeah. It's not us thinking, oh, we're going mad. Actually, we know your brain's going through a big shift because it's adjusting to a new norm without hormones. And that takes time. And we're all different. Some people will notice that more than others because all of us are unique.
Wow. Yeah. Gosh, it's amazing when you even think about that, scanning people's brains and being able to see a difference. It's unbelievable, isn't it?
I just really feel it for like my granny and the previous generations,
100%.
You know, that just didn't have this knowledge, and it was all just very much under the carpet.
It was under the carpet. Don't tell anyone.
And it's just sad when you think about it. So it's just great to live in a time now where all of this is happening, and support and new drugs, like you said. I know you touched off there some of the really common side effects. Is there some maybe less common that people maybe wouldn't be that aware of?
Definitely. I'm going to throw in one more common one, which would be insomnia, not sleeping. That's a huge symptom. And I think that when I see patients, that and cognitive symptoms are the ones that can be quite difficult. So I would say look at good sleeping strategies, know that there are options out there, whether or not that's medication, cognitive behaviour therapy, support, because sleep is really important for your overall health. But when
vaginal dryness is something actually we see a lot in the hospital as well. I know you touched on that just a little bit earlier on, but there's lots of non-hormone based creams and gels and stuff that there's available, isn't there?
There is. So I would also say that for some women, you can look at local estrogen as a possibility because you're not absorbing that into your system. So local estrogen is just estrogen in the form of a cream, a pessary or a ring that can be given locally for symptom relief of vaginal and urinary symptoms. We can also give non-hormonal moisturizers. There's also other types of medication that can help. So know that there are options. And I think the key thing is it's one of those symptoms where we think, well, let's just see if it disappears, or let's just not say anything, because nobody wants to go into their doctors and say, do you know what, I've got an itchy vagina. Nobody wants to do that, even me. It's not it's not something that we talk about, but actually it's something that's there. It's something that's quite common, much more common than vasomotor symptoms, because think about that pelvic area, very sensitive area, sensitive to hormonal changes. And potentially we do have a good range of treatment options available, whether or not that's hormonal options or non-hormonal options. So it's also understanding that there are options. And even if you don't feel able to talk to your GP, even if you're able to, there's a really great book called Me and My Menopause Vagina by Jane Lewis. You can get it on Amazon. It's bright yellow with a lolly on the front, so you can't miss it. And she's designed it that way because she was a lady who was inflicted quite severely, so she couldn't sit down, she couldn't wear trousers. And she thought to herself, I need to make sure that other women don't feel or go through the same experience. And in her book she has a lovely diagram, so you can even just go in, open the book and point at it if you don't want to talk about it, so that you're getting however you want to communicate to your healthcare professional, because we're fine with it, we do it day in day out, but it's not the same for our patients.
Absolutely. Yeah, you're so right. And then some of the least common symptoms, least common, is that a word? Side effects.
Symptoms.
I think the least common is a burning tongue.
Oh, wow. Never heard of that, actually.
Very few women. I've had a couple of women and they'll say that they get this horrible taste in their mouth and their tongue feels like it's on fire. So that's a really uncommon symptom. Like electric shocks and tingling fingers, like you get out the car and you get that zap sometimes. That's also a symptom because again, we've got estrogen everywhere.
Right.
And the other one that's kind of hovers between the two that's really important is dry eyes. A lot of women won't pick up on that. That's quite common also in premature menopause particularly. So your eyes need lubrication just like other areas in your body. So potentially it's also being mindful because that can be treated really effectively with some dry eye drops.
Yes.
And obviously, if you're looking at screens, which we all are way too much and we know we shouldn't, it's just understanding that can affect it as well.
Brilliant. Gosh, wow, I've never heard about the tongue one before. That's definitely a new one for me. And you were saying earlier there's 36 symptoms that we know of at the moment, side effects that we know of at the moment. Is that right? Yeah, 36. So this is quite a difficult question probably, but is there an expected time frame that people may expect to experience these side effects?
My answer is there's no time frame, and I know that all your listeners will hate me for saying that, but that's because we're all different. So as I said, some women have in menopause at the expected age have no symptoms at all. Fantastic. So when we're looking at this particular group of patients, potentially it could be that you get symptoms, you notice symptoms straight away after your surgery or medication, or you may notice it a few months. But there isn't any sort of time frame where we can say, well, by the end of the year, they'll all have stopped, because we're all different. It's all about how your body is adjusting to the new norm and that new and that hormonal change. So potentially, I'm sorry to say I can't give a specific answer, but what I can say is that we're so much better in actually getting awareness out there, talking about it, and we've actually got some good treatment options that we can offer you and support.
That's brilliant.
So are there any long-term side effects of the menopause on the body?
It's really good to think of short-term and long-term, Anne-Marie, I would agree. So obviously we often talk about symptoms or side effects, and often we are focused on those ones that are happening right now because we're like, well, I want to get rid of those hot flushes or that vaginal dryness, of course. But actually thinking long-term is really important, because how long are we all living? I'm in my early 40s, and back in the day, I'd be the village elder, wouldn't I?
Yeah.
Whereas now, how long are we all living? 70s, 80s?
Yeah, exactly.
I'm only in the middle, apparently.
Yeah.
So it is important to think short term and long term. And we know the data tells us that more women are affected by cardiovascular issues post-menopause than they are before their menopause. So that tells us that those hormones are a protective factor. So obviously it's understanding there's a cardiovascular risk. And we also know, obviously, that when our body doesn't have as much estrogen, that has a big impact on our skeleton. The bones in our skeleton really like estrogen. It's a good building block to keep our skeleton strong. And when we don't have that same level, we're all more likely to have osteopenia or osteoporosis, where the bones in our skeleton are more likely to become at risk of fracturing. And a lot of women will say to me, I've got joint pain. I get up and I feel like an old person. And actually, what we do know is that there's some really good treatments, both medical and lifestyle changes, that can help. HRT, for example, is a treatment for osteoporosis, but may not be suitable for this particular group of patients. We have other medication we can use. We can do bone scans to check what's happening with your bone density to see if you're at risk, because again, we're thinking short term and long term. And things like diet and lifestyle, so having a good diet, being active, strength training, exercising, we know are really important to keep your bones strong.
Fantastic. And then can you recommend any complementary therapies that might be beneficial in managing menopausal symptoms?
I always think of menopause as a toolkit. As I've said, it's not a case of taking one medication and it's solving all the problems. So I think potentially there are some really good complementary therapies. Some ladies tell me that they really like things like reflexology. So that's the therapy where they do lots of lovely things on your feet. You feel relaxed while you're there, you feel reassured. Some ladies like acupuncture, so they use the little needles. We also know potentially therapies that can be helpful, as we mentioned before. Yoga and meditation can be really helpful for feeling more relaxed, for gentle stretching movements that are really important for your fitness. So I think potentially those can be really good. And I also think asking the patient what they normally do. So some patients will say to me, I don't know if I want to go back and do my reflexology. Well, did you do it before? Yeah, and I really liked it. Well, there's no problem with that. It's not going to interfere with your treatment. Why not go back and see your reflexology if it made you relaxed, it helped you navigate the symptoms? Because also we've all got our own coping strategies that help.
Exactly. And then is there any resources that you could recommend for people that they might find beneficial?
Quite a few, actually.
Yeah. And we'll link them all if we can on our Instagram page.
The first one I'm thinking of is there's a new, I'm going to get the right word for it, like a new self-help journal, and I'll send you the link for it. It's by a lovely lady called Ginge Unhinged. I mean, what an awesome Instagram name is that.
Love it.
And she's a lady who has gone through surgical menopause, and she has just developed kind of like a journal and a resource for patients. And I've ordered one. It's coming, so I'm looking forward to doing a review so I can tell patients.
Brilliant.
But I really like this one because it's a patient who's been through that experience.
Yeah.
It may not be specifically the same experience to what some of your patients are going through, but it's very similar. So she's got things in there that you might be able to relate to. She's got ideas in terms of support, journaling, so loads of different options. So that would be the first one, because that's something once that's out that you can probably get quite, you can order that yourself. You can you can make an informed decision, purchase it yourself. It's not too pricey. I would also say have a look at something like a symptom checker, or if you've ever heard of the Balance app, in the UK, it's a menopause app where you can chart your symptoms. You can have a little diary. It's all on your phone. So this fits with new technology, which we all know we're on. So you can download it. You can have a symptom checker on there, which I've talked about. If you want to keep a record of symptoms, a journal. You can read up about lots of evidence-based treatments, whether that's HRT, right the way through to all of those complementary treatments or those other medical treatments. Because I don't know about you, if you're a patient and you've been thrown all this information and then you say, oh, I was supposed to go away and look up such and such. Well, what am I going to look up? What am I going to do?
Yeah.
It's having that information.
Yes.
I would also recommend that book if you're having some, if you're concerned or you're experiencing vaginal symptoms. The book Me and My Menopause Vagina by Jane Lewis, because it's an open, honest, and also a humorous book. And I think sometimes that's quite nice. It's a bit of a change to have a little bit of humour, and again, something that you can get hold of.
Oh, listen, Kate, thank you so much. It's been great. It's been so informative, and I think so many people are going to benefit from the conversation. So thanks so much. And just to let everybody know, it is like 6:00 in the evening, and Kate's come after work. So
fine, it's a pleasure. I've been really looking forward to it, and I welcome any questions, because even as healthcare professionals, for us, every day is a school day.
Yeah.
We don't know all the answers, but we're a team and we find someone that does.
And just in case anyone wants to follow you, what is your Instagram handle?
It's fertility_menopause support. And as I say, I cover fertility, premature menopause and menopause. So it really covers everything, really. And at the moment, I work a combination of Ireland and the UK, which is why I kind of picked your brains about what's happening in Ireland as well as here. So it's actually quite nice to be in a position where I'm able to actually make a difference in both countries, actually. Even though I've only been here a short time, it's been really, really rewarding.
Making an impact.
And just to sort of add some positivity to end, my students have just finished their first year in their master's course, and we did have a big session on menopause, not just menopause at the expected age. We covered premature menopause, surgical menopause, because I'm just really keen that we need to be educating so that these wonderful nurses are in the position to support the patients going forward.
Yeah,
absolutely.
Because I think back to our training, there wasn't even one lecture on menopause, and it's so important. So it's great to hear that it's brought into the master's program.
These are all specialist nurses who are working in women's health, so they've got the bug.
Yeah,
but because this is potentially where patients are going to present and where they're going to need that support, and giving them the knowledge and confidence to do that and spend the time and support these patients, because that gives it also motivation and hope to any patients listening because we like to know that things are things improving, and it's really good to be able to say yes, we're hopefully making a difference.
Absolutely.
Okay, thank you so much for your time. It's
Pleasure.
been great talking to somebody who's so confident in this area, and you've just amazing.
I've loved it. As you can guess, I could talk all day, but thank you all very much. It's been an absolute pleasure.
Thank you.
Thanks for listening to the Answers for Cancers podcast. Please share this podcast with anybody who you think it might help. Also, if you can like and subscribe, it lets people know we're here. You can alternatively contact us on Instagram at the Answers for Cancers _podcast. And if you've any questions on anything that we discussed today, please email us at the Answers for Cancers podcast @gmail.com, or you can DM us on Instagram.